Yeah, I'm not really going to repeat the importance of laparoscopy now in all the area of surgery and the advantage of the laparoscopy. But in Senegal, in the beginning, it was only for diagnosis, even in urology. And after, we have therapeutic between 1992 with thoracoscopy, vasectomy, and after, we began really with cholecystectomy. Feasibility is well established in universities, hospitals, in private clinics, and we have equipment even in all the areas in Senegal. Numerous publication in local, regional, and international scientific journals. Our problem now in Senegal is how to teach laparoscopy now. We have the surgeon in activity, the surgeon in training, and the surgeon in regional hospital. We have a lack of consensus in how to teach it. Simulation, monitoring, virtual reality simulator. We have the choice. But we think that it's an obligation now for all surgeons in all areas to use laparoscopy when we have the equipment. In the first 10 years in Senegal, we have only monitoring. We have the same monitor with all my colleagues here in the room here. We have doing only monitoring. And after, in the second 10 years, it's necessary now to have a training program. And we have a diploma in our university, but we start with periodic workshop with theoretic session. We have a lab, and then in the second day, we are going to the OVA to have demonstration. This is 2 years ago, but now we developed one lab. We will use device for simulation. Here we work with nurse but our philosophy is we have to learn laparoscopy together, surgeon and nurse together. And here we are in the lab simulator. And in the next 2 years, we start to use PIC in the lab. Here we have the management of the laboratory. We try to use all the devices necessary for laparoscopic surgery, electrosurgery, or all the new devices. And after, we have simulation in PIC. And after the second day, we go to the OVA and the monitor doing a simulation in a real person. We do that, the training program workshop in the second day. And after, we do a certificate of participation. Here we have most of the surgeons of the not real area, but the other city of other country in Senegal. And after, we develop a new concept. After this, we have a mentoring in their own hospital, like outreach. And here we have the hour of a regional city in Fatick, is 200 kilometers of Dakar. And we develop here a program of under tour with the participant of the practitioner in Fatick. We have gynecologist, one urologist, and one general surgeon. Now, the situation in Senegal is all the big area have in yellow have a tower of laparoscopy. And I report our can I say that? Our experience and my own experience in my hospital. We have other experience in other hospitals, but in our hospital we have around 500 cases. Mean age, with the mean age, and the intervention we have 35 per year, 3 per month in mean. And the result we have biliary pathology, esophageal duodenal pathology, and exploration. Here we have in the biliary pathology, the main case have polycystic egg. In the main of the time, it was in a patient with gallbladder, but in sky cell disease. For esophageal pathology, we have achalasia, hiatal hernia, and ulcer. Here, all these indications are validated: vagotomy truncular, chloroplasty, achalasia, hernia, and exploration for gynecology disease. It is a monocentric result with 85 therapeutic laparoscopy, few conversion, few morbidity, few mortality, and main state is very short. What is the future? We have to extend our indication for colonic resection, bariatric surgery, and perhaps using single port. And if you see, we must consider laparoscopy as an aesthetic approach. It means a surgical method on both. How say Professor Lamte, we have to proceed your open surgery and you use laparoscopy secondly. Perhaps one day we are going to use natural endoscopic surgery or laparoscopic single port, and the laparoscopic surgery will be the classic age of endoscopic surgery. Thank you for
boards in pediatric surgery in the United States, and you start talking about CT scans. After being shown this X-ray, you will feel that question. So this is still a classic. Obviously, there's always sometimes the questions of stenosis versus atresia. Is it totally blocked off, or is it just stenosed? And of course, a repeat X-ray will then show you some distal air. Obviously, consider an echo to rule out echocardiography, to rule out any cardiac abnormalities, and pre-op antibiotics in the operating room. The required skill set, definitely, before you embark on this, you have to be really very proficient in your basic laparoscopy skills. This is where what has been spoken about by the previous two speakers in terms of simulation would be very, very helpful. Working on a 1-week-old baby, practicing your suturing skills is not really appropriate. Okay, so safe dissection technique and the ability to suture and tie intracorporately. This is just some of the instruments that are used. Obviously, they are designed for a younger audience. And there's not really much of a need for a lot of the fancy things that are used in laparoscopy, such as the harmonic scalpel and other types of energy